person, but at least this is an opportunity to exchange information and experience among us. And the topic, as you mentioned, is the LH for ovarian stimulation. And this is my disclosure. Now, we know that there are two gonadotropins at work during ovarian stimulation, and in almost all animals, LH and FSH. And we also know nowadays that they do have different functions and different regulation, and that's why they are important, and we have to have a look what happens in the natural cycle. Well, in the natural cycle, the FSH is important for the recruitment of the follicles and to the growth of the follicles at the first part of the follicular development. But becoming a competent oocyte and a competent follicle happens in the second part of the developmental situation in the follicle, and it is LH dependent. We also know that from the point that the follicle will reach a dominance of between 10 to 12 millimeters, there are around 5 days until LH surge will occur. And this is the point when FSH started to decline and decrease, and LH will start slowly taking over the influence on the follicular development and the competence. Now, the TICA cells have permanently LH receptors, but the granulosa cells had at the beginning of the follicular development mainly FSH receptors. In the TICA cells, androgens are produced, and the androgens will be after that aromatized in the granulosa cells to estradiol. But we also know that the androgens will increase the sensitivity of the granulosa cells to FSH. So we have indirectly, already from the beginning of the follicular development, an indirect effect of LH on the granulosa cells for the recruitment, initial recruitment and the initial growth of the follicles. As we see here, this is a study from the Copenhagen group. During development of the follicle, more and more LH receptors will appear on the granulosa cells, and there is a decrease of the FSH receptors on the granulosa cells. So at the pro-ovulatory follicle, it becomes more LH dependent and less FSH dependent, and it is different at the beginning of the follicular development. Now, LH and FSH secretion depends on positive and negative feedback signals, and you can see here a lot of possibilities that can affect this axis of hypothalamus, pituitary, and ovary. And there are different situations where we shall have deficiency of LH and FSH. This can be congenital, acquired, or a functional situation. And a failure for the kind introduction and also for inviting me to participate in this conference. I do regret that we are not able to meet in person, but at least this is an opportunity to exchange information and experience among us. And the topic, as you mentioned, is the LH for ovarian stimulation. And this is my disclosure. Now, we know that there are two gonadotropins at work during ovarian stimulation, and in almost all animals, LH and FSH. And we also know nowadays that they do have different functions and different regulation, and that's why they are important, and we have to have a look what happens in the natural cycle. Well, in the natural cycle, the FSH is important for the recruitment of the follicles and to the growth of the follicles at the first part of the follicular development. But becoming a competent oocyte and a competent follicle happens in the second part of the developmental situation in the follicle, and it is LH dependent. We also know that from the point that the follicle will reach a dominance of between 10 to 12 millimeters, there are around 5 days until a late surge will occur. And this is the point when FSH started to decline and decrease, and LH will start slowly taking over the influence on the follicular development and the competence. Now, the TICA cells have permanently LH receptors, but the granulosa cells had at the beginning of the follicular development mainly FSH receptors. In the TICA cells, androgens are produced, and the androgens will be after that aromatized in the granulosa cells to estradiol. But we also know that the androgens will increase the sensitivity of the granulosa cells to FSH. So we have indirectly, already from the beginning of the follicular development, an indirect effect of LH on the granulosa cells for the recruitment, initial recruitment, and the initial growth of the follicles. As we see here, this is a study from the Copenhagen group. During development of the follicle, more and more LH receptors will appear on the granulosa cells, and there is a decrease of the FSH receptors on the granulosa cells. So at the pro-ovulatory follicle, it becomes more LH dependent and less FSH dependent, and it is different at the beginning of the follicular development. Now, LH and FSH secretion depends on positive and negative feedback signals, and you can see here a lot of possibilities that can affect this axis of hypothalamus, pituitary, and ovary. And there are different situations where we shall have deficiency of LH and FSH. This can be congenital, acquired, or a functional situation. And a failure to generate secretion or action on any disruption of gonadotropin action is defined as LH-FSH deficiency, and the congenital possibilities are either the hypogonadotropic hypogonadism, the hypo-hypo situation, or we can have polymorphism of the LH or the FSH molecule or the receptors, the LHCG receptor or FSH receptor. Acquired situation for deficiency can be generate analogs used during stimulation for ART, but also eating disorders, hypothyroidism, diabetes mellitus, and also functional hypothalamic amenorrhea, like a situation of over-exercise, can cause a deficiency in LH and FSH secretion. So how much LH is actually needed during the follicular development? Well, the LH activity which is required is actually very low, because studies have shown that if less of 1% of the LH receptor are occupied, we can have an optimal, still an optimal steroidogenic response. And during ovarian stimulation, we are using nowadays either long GnRH agonist protocol or antagonist protocols, but in both of them you can see that we reach situation where the LH level is very low compared to the natural cycle, which you see up here. This is just one example from an Australian group looking at antagonist cycles, and they measured the LH one day after started the antagonist, and they differentiated between two groups. The one group stayed with the LH above 1 international unit per milliliter, and the other group dropped less than 1 international unit per milliliter. But when they looked at the outcome of this group that dropped very low, you see that there was a significant reduction in the implantation rate and pregnancy rate compared to those who did not drop. Giving 75 units of LH from the first day of the stimulation in this second group corrected the outcome of the treatment, and there is no difference now between the group that did not drop compared to the one that have been corrected now. When they analyzed all the cycles that they are treating, they found that about half of the antagonist cycle have this kind of drop after LH, after 8 antagonists start measuring LH. Another problem group are advanced maternal age patients, because the aging of the ovary have very important changes. For example, we have less functional receptors at the theca cells and the granulosa cells. We also know that the endogenous LH is changing over the age. There are other less biological active isoforms of LH that come up in advanced maternal age, the same as the problem with the FSH. And we also have an impaired ovarian paracrine activity in the system during the aging. Also, androgen production, as you can see here, is dropping significantly over the years in advanced maternal age. Now, low levels of LH can negatively impact the outcome of our treatment. And as you can see here, many publications look at this problem. To summarize, there will be a reduction in implantation rate, there will be an increase in early pregnancy roles, and a reduction in the live birth rate. We know that FSH-dependent granulosa cells activity can improve when LH is given in control ovarian stimulation. For example, increase in ovarian follicular angiogenesis. We have an improvement in follicular recruitment by increasing the sensitivity of the granulosa cells via the androgen production. And we have an increase in follicular maturation by expression of maturation markers that you see here on this slide. We also know that LH in advanced maternal age will upregulate growth factor like FGF2, amphiregulin, epiregulin, and will work and act synergistically with IGF-1 for the benefit of the development of the follicle. And also there will be a reduction of apoptosis, especially of the cumulus and granulosa cells, which are important to the end maturation of the oocyte. It is also known that LH will enhance expression of anti-apoptotic proteins in the follicle. Now, in a situation when we have a very low LH, for example, in agonist, long agonist or antagonist cycles, we try to overcome this situation by increasing the FSH dose. Increasing the FSH dose will enhance the paracrine network like inhibin and growth factors, and will make the receptors on the theca cells even more sensitive to the very low amount of LH, so we can correct the situation by high levels of FSH. This might work very well in young patients who have a very good paracrine system, but as I told you, the older patient, the paracrine system is not very active like it's in the younger ones, so they will not be able to adapt to the situation of very low abnormal age just by increasing the doses of FSH. And a collaborative group published in 2018 this review article. I was part of this group, and we found that in two cases we can definitely suggest, according to the scientific data available at that time, that use of recombinant LH supplementation will benefit the outcome of the treatment. So the first group that was scientifically proven is the hyporesponder group. And the second group that we could definitely say that there is enough scientific evidence is the advanced maternal age group over the age of 35. Here just an example, you see one of the papers looking in hyporesponder patients. Having LH supplementation will increase the implantation rate significantly, and also the clinical pregnancy rate will significantly improve by additional of recombinant LH to the stimulation. There was a question if recombinant LH will increase the number of the oocytes in poor reserve patients according to the Bologna criteria. And the SPART study, published in 2011, showed that actually an LH will not be able to increase the number of the oocytes in this subgroup of patients, but the quality of the oocyte became better by adding recombinant LH in the subgroup of patients that have been identified as moderate or severe Bologna criteria patient. They had a lower pregnancy loss with addition of recombinant LH and a higher live birth rate. And just last month, this publication in RBM Online by Lehert showed in a large database looking at a total of almost 10,000 poor ovarian response instances of ovarian stimulation. Half of them receive LH supplementation and the other half only recombinant FSH. And what he could show was that also the cumulative live birth rate in the moderate and severe Bologna criteria poor responder group was significantly better in the LH supplementation group. Now, the other question when using LH is the starting point of LH, because many studies showed in the past different outcomes, especially in advanced maternal group patient. But the difference between the study was the starting point of the LH. So this study, published in 2015, looked at this question and randomized advanced maternal LH patients in long agonist protocol, either receiving recombinant LH from the first day or adding recombinant LH from day number 6. And what they found was that in the group where it started from the first day, significantly higher implantation rate, clinical pregnancy rate, and ongoing pregnancy rate could be achieved. So the lesson from this study is that starting LH in LH supplementation cycles should be from the first day in order to achieve all the advancement that LH will bear with. We can also use nowadays the Poseidon subgroup criteria. And as you remember, group 1 and group 2 are hyporesponder patients. The difference is here only the age. So this is the over 35 and the younger patient. And in hyporesponder groups, LH supplementation will be of advantage. And here for 2 reasons, for the advanced maternal age plus the hyporesponse. And group 4 will be the patient which are similar to the Bologna criteria moderate and severe group. They will benefit here from the outcome of a treatment because a better quality of the oocytes, so a higher live birth rate or cumulative live birth rate. So we can use the Poseidon stratification also for decision for using LH. So what are potential sources of LH? So either we can use recombinant LH nowadays, either just by itself or a combination of FSH, and this is quite pure LH activity. And we can use urinary LH, where we're supposed to have 75 units of FSH and 75 units of LH. Unfortunately, analyzing the LH activity, it derives from HCG, and the reason is because of the very high purification nowadays of the urinary product. The LH molecule is lost, and that's why the pharmaceutical company add small doses of HCG to achieve an LH activity. So the question is, do we have a difference if we use HCG or LH for LH activity? And the question is, yes, there is a difference. Because both of them attach to the same receptor. It's called the LHCG receptor on the membrane of the cell. But when they attach, they can go in 3 different pathways. Either they go to the cyclic AMP pathway or the phospho-ACT and phospho-ARC. Cyclic AMP is important for steroidogenic activity, but phospho-ACT and phospho-ARC are important for the development and maturation of the follicle in the oocyte. Now, studies have shown that the receptor can identify the molecule that attach, and according to that, it will have, it's going through different pathways. Now, HCG is more active, 5 times more active than LH on the cyclic AMP pathway. So it's an excellent steroidogenic producer. But we know nowadays also that excessive amount of cyclic AMP can be pro-apoptotic in the cell. LH on the other side is more active in...
Es liegt leider ein Problem mit der Internetverbindung vor. Versuche es in einer Weile erneut.
We have LH more active than HCG in phosphor-ACT and phosphor-ACT activation. And according to that, we can say that LH is an anti-apoptotic growth differentiation and survival factor. And HCG is a more steroidogenic but pro-apoptotic factor. So LH and HCG are not equivalent in vitro. And there are also potential deleterious effects of HCG versus LH. We know that HCG has a longer half-life time than LH, 3 to 4 times longer, so it will accumulate in the serum. And this accumulation can cause a downregulation of LH and HCG receptors, and it can happen on the ovarian level and on the endometrium level. And this can affect, of course, the development of the follicle and the oocyte and the implantation. And we also know that it is less effective in implantation and pregnancy rate according to these studies here. So LH and HCG are also not equivalent in vivo. And when we look at one of the latest meta-analyses by Santi in 2017, we see that comparing now recombinant FSH with recombinant LH to FSH plus HCG, which is HMG, you see that there is a big difference in the number of the oocytes. First, of course, it is much higher with the FSH with LH, but also the quality of the oocytes, the embryos, implantation rate and pregnancy rates are higher for the FSH LH compared to FSH and HCG, which is the HMG product. And lately, probabilistic decision tree have been published to look for the efficiency of the treatment compared between HMG and recombinant FSH and LH. And what they found in this probabilistic decision tree, when 1,000 patients entered and had 3 fresh cycles within 2 years, and divided into different responders, so poor responders, normal responder, hyper responder. What they found was that the time to pregnancy was lower in the FSH-LH group compared to the HMG group. So although the HMG was cheaper in buying the medication product compared to the FSH-LH, at the end, the cost per pregnancy was identical. Actually, it was cheaper in the FSH-LH product compared to the HMG because more pregnancy could occur in the same time. And it was even more significant in the normal responder patient between 10 and 15 oocytes, which are actually the majority of the patient that we are treating. So to conclude, 2 gonadotropins, FSH and LH, are at work in almost all animals and humans. And we know now that they do have different functions and different regulations. Low FSH and low LH can be congenital, acquired, or functional. And LH given during ovarian stimulation will exert stimulatory effect on FSH-dependent granulosa cell activities and pteridogenesis. LH is important for oocyte competence, and it will benefit patients who are hypogonadotropic hypogonadism, severe poor responders, patient older than 35 years old, and hyporesponder patient. And one should start the treatment with LH supplementation on the first day of control ovarian stimulation. I also showed you that LH is different than HCG at molecular, functional, and clinical levels, and recombinant LH and HCG provide LH activity using different mechanisms. HCG is predominantly pro-steroidogenic and potentially pro-apoptotic, and recombinant LH is predominantly pro-growth differentiation and maturation and survival factor for the oocyte. Thank you very much for your time, and I am happy to answer you.